Hello, everyone. We'll get started in just a few minutes. Hello, everyone. We'll get started in just a few minutes. Hello, everyone. We'll get started in just a few minutes. Hello, everyone. We'll get started in just a few minutes. Hello, everyone, and welcome to the Society of Critical Care Medicine's ARDS Innovation Knowledge Education Group. Thank you for joining us today. My name is Javier Amador Castañeda, and I am one of the ARDS Innovation KEG co-chairs, along with Dr. Bushra Mina, who will be here very shortly. We'll get started promptly at 3 o'clock, so 5 more minutes. Thank you. Where's Dr. Mina? Hello, everyone. All right, hello, everyone. My name is Javier Amador Castañeda, and welcome to the Society of Critical Care Medicine's ARDS Innovation Group. I am one of the co-chairs, along with Dr. Bushra Mina. Dr. Bushra Mina, can you introduce yourself, please, and any disclosures you may have?
Good afternoon. I'm Bushra Mina, Chairman of Medicine, Chief of Pulmonary Critical Care at Northern Worcester Hospital in New York, and I co-chaired the ARDS for the Society of Critical Care Medicine. We have the pleasure here to have a great speakers, and we would like to introduce Dr. Richard Greendyke from Columbia University to introduce the speaker and moderate the session.
Wonderful. Thank you so much, Javier. Thank you, Dr. Mina. My name is Richard. I'm a pulmonary critical care doctor from Columbia University, currently doing a postdoctoral research fellowship up at the University of Toronto. And now it's my great honor to introduce today's very distinguished panel of speakers. So first, speaking today will be Professor Eddie Fan. He's a professor of critical care medicine at the University of Toronto, serves as the medical director of the extracorporeal life support program at Toronto General Hospital, and he is internationally recognized for his research on advanced life support for ARDS and also long-term outcomes in critical illness. Speaking second today will be Professor Giles Peake. He's a professor of cardiothoracic surgery at the University of Florida Health Congenital Heart Center. He pioneered the United Kingdom's first pediatric mobile ECMO service and has led programs in adult, pediatric, and neonatal ECMO. His expertise spans congenital heart surgery and ECMO for both cardiac and respiratory support. And our final and third speaker will be Professor Alan Combs, who's a professor of intensive care medicine at Sorbonne University and head of the ICU at La Pitié-Salpêtrière in Paris. He's a past president of Euro-ELSO, a leading voice in ECMO research, has been instrumental in advancing extracorporeal support for cardiac and respiratory failure worldwide. So we're really fortunate to have such extraordinary faculty with us today. Please note that you can access their full biographies under the resources section, and that's just at the bottom of your screen. So without further delay, let's begin today's session. Each of our speakers will provide expert-driven insights on ECMO and ARDS, after which we'll open the floor for discussion and audience questions at the end. So with that, Dr. Fan, the stage is yours.
Great. Thank you, Richard, and thanks to all the organizers for the opportunity to speak today. I'm going to share my screen here, and hopefully everything will... Can you guys see the right screen? Okay.
Yeah, we can see that.
I'll take that as a yes. Okay, so thank you. So I'm going to kick things off today talking about, in this session on ECMO for ARDS, about issues around patient selection and nuance beyond the guidelines. Here are my disclosures. I won't be speaking about any specific devices in my presentation today. Okay, so I think, starting with the guidelines, as the title suggests, is that we actually now have guidelines from many jurisdictions around the world. In today's talk, I want to highlight two. Describing the use of ECMO for severe ARDS. The first is the guideline for the European Society of Intensive Care Medicine, which now in 2023 makes a strong recommendation for the use of VV ECMO in severe ARDS patients, either due to COVID-19 or not due to COVID-19. And clearly, even in this recommendation, you could see in the middle of the screen, makes a specific and explicit recommendation about patients as defined by the EOLIA trial eligibility criteria, the EOLIA trial being led by Professor Cohn, who will be speaking later in today's session. And they should be treated in ECMO centers that meet defined organizational standards, adhering to management strategies similar to that used in the EOLIA trial. Again, sort of making explicit the issue that since the two modern randomized controlled trials, and again, Dr. Peake having led the CSER trial and the EOLIA trial, really make the evidence base for the use of ECMO in these patients that we're talking about today, that the benefits that we see in those trials would likely be best obtained by adhering to the inclusion and exclusion criteria. Those are the candidates that we're seeking to use ECMO therapy in. Similarly, in an update to the American Thoracic Society guidelines that we published early last year. We also made a recommendation for the use of ECMO. I apologize, the script is maybe not so clear, but again, we also did make a very explicit move to delineate that the population that we think that should be undergoing ECMO for severe ARDS, again, meets the criteria, whether you're talking about hypoxemia or hypercapnia, should meet the inclusion criteria that were used in, again, both the modern trials of ECMO therapy in these groups, including Caesar and Eolia, and similarly consider some of the exclusion criteria or the contraindications that were considered in those trials when thinking about who are the right candidates for this therapy. So guidelines again exist. The guidelines both now suggest who the candidates should be and how we make patient selection. We try to maybe make that a bit more expanded in a recent version of the ECMO guidelines published by the Extracorporeal Life Support Organization, or ELSO. And here again, I'm not going to go through all the points on this slide, but just to say that if you wanted to access a more comprehensive list of things where we think about clinical conditions that would be indications, clinical situations that may be either relative or absolute contraindications to ECMO therapy, they're listed here in this guideline led by Joe Tona and members of the ELSO organization. And again, you can see at the very top, the common indications, again, really codify those inclusion criteria that were used in both the Caesar and Eolia trials. There are some examples here of specific clinical conditions that might lead to, again, a refractory hypoxemia or refractory hypercapnia situation. Again, at the top of the list is the ARDS, which is our focus today. That could be triggered by all kinds of insults. But again, there are many conditions here that you could see, including alveolar hemorrhage, thoracic trauma, severe asthma, the development of a bronchopleural fistula that also might present themselves as candidates that could be considered for ECMO therapy. And then here again, you see a list of relative contraindications. Again, I don't think any of these will be too surprising to the audience today, but including things like that are relatively catastrophic and perhaps more prognostic than the respiratory failure these patients might have, including things like widespread or disseminated malignancy, central nervous system hemorrhage, severe CNS injury, and these sorts of things that, again, are likely to have a bigger and more profound effect on the outcome of the patient than the respiratory failure that we're trying to support with ECMO. So those are the guidelines. And I want to stress, having participated in a number of guideline exercises for various professional societies, including the ones that we just talked about, is that the name says it all. Guidelines are guidelines. They are not rigid, hard and fast rules about candidacy, patient selection, management strategy, and that sort of thing. We should see guidelines as guidelines. Clinicians should make, obviously, the best choice that they can on a case-by-case basis, treating the patient that's in front of them. And the guidelines might represent a good starting point when you're considering things like patient selection around ECMO. It's a place where we can begin the discussion, but it doesn't necessarily need to be the end of the discussion. And as the title of my talk suggests, there are going to be nuances beyond the guideline that we should consider. I just want to highlight that some of these nuances now are being driven by extra information or data that we're gathering about some of these patients and how it might affect patient selection. So I just want to highlight some recent studies that may help us guide us in the decisions around some of these important questions. This is a nice study led by Shannon Fernandos, one of my colleagues here in Toronto, who used the ELSO registry to look at the association between age and outcomes with ECMO. Again, I don't think it's earth-shattering to sort of understand that as age increases, the outcomes from patients supported with ECMO unfortunately gets worse. But what's interesting about this study was, if you focus on the graph on the right, is that it's a pretty linear association. There really isn't a threshold effect. So again, here's some of the nuance. If you think about clinical trials that had inclusion and exclusion criteria that maybe had an upper limit in age about 65, 70 years old, and maybe perhaps many clinical programs also use some kind of age cutoff there, it's important to understand from studies like this that actually it's not like a threshold effect, right? It's not like the mortality from being supported on ECMO is pretty similar until you reach some threshold of age 65, 70, or 75. That risk is steadily increasing across the increasing deciles of age. And so here you could see, even when you look at the group that's 30 to 39, going up to 40 to 49 or 50 to 59, these are still very young patients. the outcome is unfortunately worsening and mortality is increasing. So again, these are some things to keep in mind, that it's not that there's a threshold effect with age here, but that age and mortality is steadily increasing with increasing age. I think another important thing that has nuances is that some programs consider BMI as potentially a relative contraindication in these situations. And certainly, I might speak for my center during COVID, we were presuming that, again, there was a link, it seemed, between obesity and outcomes in COVID in general, but also perhaps a signal between obesity and ECMO support in patients with COVID-19. And we, in my center, also employed a BMI cutoff when thinking about candidacy. And this has long been an important question, both in ARDS and in ECMO support. But this interesting study led by Greet Hermans in Leuven in Belgium, again, using ELSO data, actually suggested that there wasn't a clear association, if you look on the left here, between mortality and higher BMI. But if you look on the right on these smaller graphs, there seemed to be, for some circumstances, an increased risk of complications in patients being supported with ECMO with higher BMI. So again, this sort of helped to reset, at least in my program, to go back to our pre-pandemic situation where we didn't have a specific BMI cutoff to consider candidates for ECMO. And again, the guidelines at the moment don't suggest a specific cutoff. But again, we take it on a case-by-case basis. And certainly at any BMI, if there's a challenge with the technical aspects of cannulation, that could obviously influence decision-making, but that BMI in and of itself shouldn't be a contraindication to ECMO support in these patients. I think another area of constant controversy is when should ECMO be deployed? And maybe more specifically is thinking around how many days of potentially injurious mechanical ventilation or high levels of FiO2 could be delivered to patients prior to considering ECMO therapy, where perhaps, again, you reach this point of no return, and there's been so much irreversible lung injury that supporting the patient with ECMO may not lead to a meaningful outcome. Again, previous clinical trials have suggested perhaps 7 days is a point where we want to consider patients for ECMO, and after 7 days, we might be a bit more reticent to put patients on ECMO. Observational data has suggested that perhaps the benefit could be extended to about 10 to 14 days. But again, it's pretty unclear, and it's hard to think that there's some hard and fast arbitrary threshold beyond which patients are good candidates and beyond which patients are bad candidates. So to sort of speak, like if 7 days was something magical, that a patient who's 6.5 days on mechanical ventilation is a great candidate, but suddenly at 7 days and 2 hours, the patient is no longer a good candidate. So maybe moving away from the idea of arbitrary thresholds could be one point. But to say that we have some data, and these are data from our group using global COVID-19 consortium data led by John Fraser, where we emulated a target trial of VV-ECMO in these patients with COVID-19 being supported with ECMO. And what we found is actually you could see a pretty consistent benefit of ECMO therapy all the way up to 12 days. So you could see a significant association with a reduced risk of mortality, even up to 12 days. We didn't really look much beyond that because the data started to become a bit more sparse and a little less precision in those estimates. But again, challenging the idea that there is some magical or arbitrary threshold around a week that should be considered. And I think, again, might caution people to think that there is some arbitrary threshold that we should use, but clearly understanding that as the duration of respiratory support increases and you're considering ECMO therapy, that's certainly what you do see in this, is that the mortality benefit is a bit bigger in the early going and sort of attenuates as the duration of mechanical ventilation moves on. And then finally, this is perhaps not so much a question of candidacy, but maybe if you think about when you should remove or think about ending candidacy. So when should we stop ECMO therapy in some of these patients? And again, in the COVID pandemic, there were a lot of patients, I'll speak for my unit, that had very prolonged ECMO runs during COVID-19. It's interesting, there's commonly this idea that the more prolonged the run, the worse the outcomes for these patients. And again, here's some nice data to help us inform us better than sort of our clinical experience from the ELSO registry that actually suggests that the amount of time on ECMO actually is not really significantly associated with mortality. So you could see here that in a large number of patients, there were 30% receiving prolonged VV-ECMO that was considered over 21 days, and the duration of support was not significantly associated with mortality. So again, if you're running ECMO and you're free of complications, free of new organ failure and this sort of thing, that the time supported on VV-ECMO should not be the sole factor in decision-making regarding withdrawal of VV ECMO support. So maybe I'm framing this as a sort of loss of candidacy, if you will. But these are important data because, again, this question comes up commonly. As we move in the future, we might develop more sophisticated algorithms to help us decide, again, on an individual patient basis with individual patient factors, who might be good candidates to benefit from ECMO and who might be bad candidates or might be harmed by ECMO. And this is the idea of exploiting the idea of looking at heterogeneity of treatment effects, because every patient is slightly different, and the holy grail of precision medicine, right? So using the patient's own factors to determine whether they'd be good candidates or not. This is just one example, looking at a study of CO2 removal, where, again, led by my colleague Ewan Gallagher, you could take baseline factors like the severity of hypoxemia, ventilatory ratio as a surrogate for dead space, things like respiratory system elastance, severity of illness scores like Apache, and you can actually use things like AI or machine learning algorithms to determine what the predicted benefit could be based on the trial results. And then we can identify patient groups that might be preferentially harmed by extracorporeal support and those who might benefit, and therefore focus our efforts on getting those patients who could benefit from ECMO onto ECMO and avoiding ECMO in patients who obviously might be preferentially harmed. And then in the end, I know I'm running low on time, so just to say that the intent is also very important. And as we think about candidacy in the future, having different indications for ECMO, maybe not just rescuing patients from refractory hypoxemia or refractory hypercapnia, but in the future, we might think of ECMO as an adjunct to help facilitate more lung protective ventilation and perhaps to get more awake, spontaneously breathing and mobile patients. Of course, these are new indications. We need to test them in trials, but to say that candidacy might evolve in the future. And again, we have some data that suggests that that could be the case, because in the secondary analysis, again, of our target trial, we did find that actually up to a PF ratio of 150. So in more moderate ARDS patients, we saw benefits. So again, candidacy and patient selection might change in the future, even around the question of hypoxemia, as we get more data. I want to end with the idea that this is not an easy situation. We know that decision-making around candidacy and patient selection for something as complex as ECMO is highly variable. And in this nice study led by Jonah Rubin, looking at his own center in Boston, they found that there were, despite the fact that they have a multidisciplinary team to make ECMO decisions, there was quite a bit of variability in the process. So that to say that in some patients, contraindications were contraindications, but in other patients, those contraindications didn't preclude patients from getting onto ECMO. And maybe like a top line message was that surgical patients who had the same complication as the medical patients typically got onto ECMO more frequently than medical ones. So again, we need to do some thinking about how we might frame decision-making better. We actually recently had accepted, and will be impressed soon, a survey of ELSO centers showing that even though they have formal guidelines, that there's a lot of inconsistency in decision-making. And even in what people decide, factors like age, BMI, or mechanical ventilation duration, what are absolute contraindications in these programs, there's not a lot of overlap. So we might need to find ways to address that in the future. We think that maybe studying this could be beneficial. So we look for centers to join our efforts in studying this further in the future to help us understand how we might improve candidacy and decision-making to promote equity and consistency in these difficult decisions. So I'm going to leave you with the conclusion that VV ECMO for ARDS is no longer if, but when and in whom, as codified in guidelines. The inclusion criteria and exclusion criteria from RCTs are the starting point, but we use nuance and clinical judgment for the patients in front of us. More data is coming to help refine our decision-making. I think in the future, we'll consider heterogeneity of treatment effect more and maybe develop EMR or EHR-based algorithms to help us determine who could benefit and who might be at risk. These decisions are very complex. Guidelines at your institutions may be helpful, and perhaps developing a standardized approach to decision-making and regular review of your decisions could be useful, and there's more work to be done. So with that, I'm going to finish, and I'm happy to take questions with the rest of the speakers at the end of the session. Thank you very much.
Good afternoon, or good morning, or good evening, depending on where you are in the world. Now, let me see if I can do this. Okay, can we see that? Hopefully. So thank you very much for joining this, and thank you, Eddie, for a great talk. I'm going to explain how a congenital heart surgeon became an ECMologist, which is what I consider myself to be, and hopefully try and answer the question as to when is the time to go on. I've no disclosures other than to say that ECMO is a team game, and the presence of the first successful neonatal ECMO patient, Esperanza, with her Dr. Robert Bartlett in the center of this slide is no coincidence. So when I first started in ECMO, we'd only just stopped doing ECMO in black and white. You had to look down your endoscope if you wanted to see the inside of the lungs. We had roller pumps and silicon membrane lungs. And you can see in the back of that picture there on the right-hand side, the newly introduced Servo 300, which was state of the art at the time. And this was the paradigm. And I suspect that it still is in many centers, that ECMO isn't considered until almost it's too late. And all of these interventions shown here on the side of the waterfall have now gone out of fashion and back into fashion again in the 30 years since I made this slide. So I started my ECMO career at the University of Leicester, which is in the middle of the United Kingdom, and was one of 4 pediatric ECMO centres. And we were doing pediatric and neonatal ECMO and very little adult ECMO at the time. And we were engaged in a trial when I joined the team. And I'm going to touch on that trial now. This is published in The Lancet in 1996. And we basically looked at neonatal respiratory failure from all over the UK, and we proved that ECMO improved survival with the number needed to treat of 3. Now, the interesting thing about this is we published this study in The Lancet, and this was the accompanying editorial written by an American neonatologist called R. Sol, which is very funny in British English, but not so amusing in American English. And what he wrote was that although ECMO is a benefit, ultimately the use of this technique is considered an undesirable outcome. And I think that that still persists, that idea. I think it's improving now that many of the gatekeepers to ECMO now become the deliverers of ECMO. I'm sure most of the people on this webinar today are not the people that were doing ECMO 30 years ago. So it's great that people are becoming more enthusiastic. And this is what I wrote at that time, and it's still true today. ECMO is the only thing we've got that allows us to rest the lung rather than continue to injure the lung. So I would suggest to you that we should go fairly early rather than waiting until it becomes a fait accompli. We shouldn't have to have lungs like this before we go on ECMO. And obviously, ventilators damage the lung when the lung is inflamed. And we've heard that from Eddie's indications that he spoke about a few minutes ago. So Bob Bartlett, the father of ECMO, tried to persuade us to answer this question by inspiring us to undertake a randomized controlled trial of ECMO in adults. And these 21 people on the roof of the Rackham in Ann Arbor were representatives of most of the ECMO teams that were doing adults in the world at that time. And what came out of this was the CESAR trial, which I was the principal investigator of. And this is my original pitch slide for CESAR from 1999. Now, I'm going to recap briefly CESAR because the selection criteria were very important. We did not do ECMO in anybody who had had more than 7 days of high pressure ventilation or high FO2 ventilation. So we didn't get the answer to what happens when you put people on ECMO after 7 days of ventilation because we excluded them. And we found a significant difference in survival without severe disability at 6 months. That was with the caveat that we use conventional ventilation in patients that could be treated conventionally in the intervention arm. That's what it looks like on a Kaplan-Meier curve. And of course, this was criticized for being a bit too pragmatic. And so I'm sure you're going to hear from Alain a bit about Aeolia later. And this is what happens when you do an individual patient meta-analysis of CSAT and Eolia patients together, looking at 90-day survival. And you can see a clear advantage with ECMO. So given that we know that ECMO improves survival in these patients, why wait? Swine flu showed us the same kind of thing. We had a huge number of patients. And this is what happens when you do a matched pairs analysis of patients that received ECMO and didn't receive ECMO. So again, massive improvement in outcome. Why wait? Now, most recently, we've all spent a lot of time dealing with patients with COVID-19, and we are all part of various collaborations. And Eddie showed you Dr. Erner's emulation study. And I'm going to share with you some more data today from John Fraser's study group, which I was part of. So this was a study that we did based on the ECMO card, or the COVID Critical Care Consortium study, and Akram Zaycock is the first author. This has been submitted, but not yet accepted for publication. But it's very interesting. And what we looked at was the time of IMV before we went on ECMO, and we compared that with the outcome. It's quite a big data set, 919 patients, obviously all adults, and we compared patients that received ECMO on the same day as they were ventilated versus patients that received ECMO later. And you can see a massive difference in survival. So much better when you put them on the ventilator and you put them on ECMO. And I think that's quite interesting. Also here, hazard ratios for various different interventions. Tracheostomy, very protective. So that alludes to the idea that waking people up perhaps and reducing their sedation footprint might be a good idea. So I'll leave you with this. We are now getting to the point where all of the things that we were told were completely crazy 30 years ago are now become the state of the art. And I would suggest to you that you should go on ECMO as soon as the patient becomes eligible. And I hope that future studies will demonstrate that that is the case. Thank you very much.
Okay, can you see my slides and can you hear me? Okay, so thank you very much for this very kind invitation. In the next 15 minutes, I will discuss with you some concepts and ideas for the upcoming years, focusing on specifically on weaning and some issue regarding outcomes of these patients. So it's first my disclosure slide. So weaning of VV ECMO can actually take a few weeks. In the Eolia trial, which was published in 2018, just a reminder that there was a trend to a benefit in favor of ECMO, with mortality was around 35. And when looking at the results of many series of patients in the last 10 years, this actually is probably one of the best estimate of what should be the target for the mortality or
whatever the survival rate if you take the opposite here in patients under VV ECMO. And when looking at the duration of ECMO, median duration was only 11 days. And of course, when we faced the pandemic, the COVID-19 pandemic, things became completely different. Well, first, there was some reassuring data about the mortality, which was actually very close to what was observed in the EOLIA trial. It was a mortality which was between 30 and 40%, depending on the series which were published. But the main difference between COVID-19 patients and the EOLIA trial patients was duration of veno-venous ECMO was close to 3 weeks here in the first wave of the pandemic in our department in La Pitié-Salpêtrière in Paris, which much longer ICU stays and also some more complications such as ventilator-associated pneumonia. Just a few slides of patients we treated during the COVID. This is the first chest X-ray we got on ECMO day 1. This is day 15, already 2 weeks on ECMO. And as you can see, the lungs are very, very damaged, and the patient is clearly not winnable at that stage. But now it's 2 months of ECMO. And well, it's maybe just a little improved with some aeration in the some areas of the lung. And then now it's 3 months. The patient is still on ECMO, and you see that there's not that much improvement. And it took us 4 months in these patients to be able to wean the patients from ECMO. So the message here that veno-venous ECMO is what we may call a school of patients, and prevent complications, treat the patient very gently, and check also for potentially winning of the patient. So just I would like to discuss now with you the recipes or some central protocols we have, because for now winning of veno-venous is mainly an art, and it's not that scientific. And there is 2 different schools here regarding the management of mechanical ventilation during the trial. There may be partial or full pressure support ventilation in conscious patients, whether other centers use ventilator-controlled ventilation in sedated, and patients who most frequently receive also some paralyzing agents. So some data here from the group of Toronto, which used the strategy of partial MV support during the trial with a gradual reduction in the sweep gas until discontinuation, which is actually the support which is provided by the membrane oxygenator. The sweep gas is the control of blood gases under VV ECMO. And importantly, also they maintain an ECMO blood flow over 3 liters per minute here to reduce the risks of clotting. And using that strategy, they identified patients with the high risks of failure, those who got higher tidal volume, heart rate, ventilatory ratio, and also large esophageal pressure swings during the weaning trial were at a higher risk of unsafe liberation from veno-venous ECMO. This is another paper published a couple of years later by the group of Luciano Gattinoni, and also data from the UK by Luigi Comparola, with this winning strategy, which was very similar here. Patients were also fully conscious under pressure support, and a gradual decrease in the sweep. And they monitored the tidal swing of the esophageal pressure, which should remain during the trial below 15 centimeters of water. The respiratory rate had to remain below 30 with blood gases with a pH over 7.25, the PaCO2 less than 60, and PaO2 over 70. with FiO2 on the lateral lung below 60%. And when the patient tolerated the full stop of the sweep gas with these parameter also, the patient was considered ready to be weaned. And when they analyzed their data in that also paper where once again the patient were fully conscious. The primary reason for weaning failure were high respiratory effort to eliminate CO2, also with more swings of the esophageal pressure, and they identified the ratio of the PET CO2 over the PA CO2 ratio, which was associated with a greater likelihood of weaning failure. The other way was the strategy which was defined for the EOLIA trial, which we also optimized for the PRO-ECMO randomized clinical trial, for which the duration of ECMO was one of the main outcome. So this is what we did in that trial. The patients were during ECMO either on VAC, ventilation, or BiPAP or APRV, with driving pressure limited to 14 centimeters of water and respiratory rate limited to 20. And there was a daily check. In VAC, the tidal had to be over 5 predicted body weight, milliliter per kilo predicted body weight, to obtain a p-plat below 24. And same also in patients on BiPAP, APRV, with a driving set at 14 to reach that tidal, same tidal of 5. The main difference is here. When the patient was considered potentially winnable, we switched to full sedation, and the patient was switched to VAC with a tidal at 6. The respiratory rate was set to be less than 28, and the P between 6 and 14 centimeters of water. Then we turned off the sweep. We also maintained here the ECMO flow over 3 liters per minute. And we checked first the SpO2, which had to remain over 90 with a FiO2 on the vent below 60%. The patient got blood gases, and ECMO was withdrawn after a full day of stopping the gas flow on the membrane, providing that PaO2 remained over 60 and the PaCO2 remained below 50, with what was considered a safe plateau pressure less than 28, and with no signs of acute coronal on the chest, on the Doppler echocardiography. So for now, once again, there's no RCT evaluating the best strategy for winning, only center protocols, recipes, and it might actually be reasonable to think about what might be the best option here, or maybe to compare 2 types of strategies for the winning phase. So how to improve our outcomes and maybe to facilitate winning? There was a lot of enthusiasm for prone positioning in the last 5 years. There was some data from systematic reviews and meta-analyses showing that, well, the survival rate was greater for those patients who did receive prone positioning during veno-venous ECMO. Although when looking at the duration of mechanical ventilation and the duration of veno-venous ECMO actually was longer in those patients who did receive prone positioning during veno-venous ECMO. And then we got the result of the prone ECMO of early proning in those VV patients. And as you remember, the trial was completely negative, with no benefit in terms of mortality and also no benefit in the time to successful ECMO winning. Of course, this study mostly included COVID-19 patients. So this actually may be reasonable to switch to conduct another RCT in more classical indication of venous ECMO. The next frontier now is to search for other strategies of mechanical ventilation under ECMO, and there's going to be trials testing the near apneic ventilation strategy. There's some animal data here from Arauz in Brazil showing that this actually might be the best strategy to protect the lungs. There's a study ongoing in the UK, the Romeo trial, which tests near apneic ventilation for 3 days with a respiratory rate of 2 breaths per minute, with a plateau set at 30 seconds for 30 centimeters of water for 3 seconds, and the PEEP set to keep the same mean airway pressure as it was before. The setting of apneic ventilation was compared with just the standard of care in patients with a PEEP over 10 and plateau less than 25. And their primary outcome measures the time from randomization to successful decannulation. So the trial is underway now, and we may have the results of that trial in the coming years. In France, we also have the Calm Down study, which is running right now, which is a phase 3 RCT. And the patients are randomized into also a near apneic strategy in which there is a first test to detect an airway opening pressure, and the PEEP is set over this opening pressure if needed. The patients are ventilated with a BiPAP APRV mode and with a respiratory rate of 0 to 4 per minute with a low frequency ventilation. The delta P is set at 10 in these patients, and the strategy is maintained for 4 days. With a comparator is also classical ventilation, as for example in the EOLIA trial with a PEEP over 10 and a delta P of 14 centimeters of water. And the primary outcome of the Calm Down study is the win ratio with a hierarchical composite outcome of mortality of lung transplantation of persisting ECMO, and a second parameter, which is number of days alive without ECMO. Is it possible to think about awake ECMOs, no MV at all? It's maybe actually the best strategy. We did some cases during the COVID. We published a letter in the Blue Journal about the results of one patient who did never receive mechanical ECMO, was only he received ECMO, he was not intubated here. He was mostly on high flow or non-invasive ventilation during this ECMO run, which lasted close to 1 month. Well, the problem is that when looking at some recent series, awake ECMO is mainly possible in patients as a bridge to a lung transplant, but very few ARDS patients were actually able to tolerate this strategy of not being intubated because of high respiratory drive. Some of these patients might also have some severe organ failures, need for renal replacement therapy, a high dose of vasopressors, in which it's obviously not very easy to set up. So, in conclusion, we now are 7 years post EOLIA. We did treat a lot of patients during the COVID pandemic. It's clear now that ECMO does not kill people, as some doctors told me when I first designed the EOLIA trial. ECMO is clearly likely to benefit to patients with severe ARDS. Also possible to say ECMO, well, not yet, or ECMO, no, because the patient is too old with too many comorbidities or organ failures. The next steps now are to organize the activity with networks and clearly more studies about the management of patients. What is the optimal ventilation strategy? Can we improve the winning phase to accelerate winning, to improve outcomes? Those are the next frontier for research in the coming years. And with that, I would like to thank you very much for listening.
First, I'd like to say a very big thank you to our three speakers for their really fascinating, thought-provoking talks and conversation. We'll start with some questions. I think some questions in the Q&A. Feel free to put things here. But maybe we could revisit one of the questions that Professor Peak answered. I think would be interested, Professor Peak, to hear some more of your thoughts and hear from Professor Fan and Dr. Combs as well. The question about what's your current ventilatory strategy for VV ECMO, and do you assess recruitability and personalized PEEP? So maybe Professor Peak, we can start just hearing some of your thoughts here.
Thank you. So I was taught what Bartlett's rest settings were when I first started, and this was the 10-10-10. And we still basically, and in pressure control as well. And we had the advantage that we couldn't measure the tidal volume. So it didn't frighten us that the tidal volume was 0.5 ml per kilo, because we didn't know what it was. Now, I am completely against recruitment of a lung that's inflamed. I think when you're ready to come off, I think that that's a different ballgame. But I think the logic of resting the lung is that you need to have enough PEEP, and that usually to me is between 10 and 15, depending on how much PEEP the patient was on when they came in and how heavy they are and how big their chest wall is, and a driving pressure of 10 in pressure control. And then the patient organizes their own tidal volume based on their lung compliance. Now, I'm sure that there are at least 100 different ways of doing this. But the problem is that if you start adjusting the ventilator, and particularly if you use any kind of volume control mode, someone is going to come in the night and adjust it. And in volume control, there's the potential that you can end up with much higher tidal volume and airway pressure than the patient can stand. So I pretty much still use 10-10-10. And I think that it works. I'm sure there's better ways of doing it. But I think Alain's case that he showed and our experience recently of people recovering after months on ECMO bears out that resting the lung means really resting the lung and not trying to recruit it until you think it's got better.
Thank you so much, Dr. Peak. Dr. Combs, do you have sort of thoughts or a take on the role of recruitment?
I mentioned the airway opening pressure. I think it's very important here because we know that up to maybe 1/3 of the patients on VV ECMO in the first days have such an opening airway of the airway pressure, which might be up to 14, 15 centimeters of water. And if the PEEP is set below that threshold, you might actually have some atelectroma during mechanical ventilation. So this is clearly the first step here. And it is very simple way here of the way to determine the airway opening pressure is very simple, just with a slow infusion of the gas through the membrane, through the vent into the lungs, and see if there is at some point an increment of the curve, which determines the airway occlusion pressure. So this is the first step for us. Then we use a pressure mode, which is the APRV. The main advantage of the APRV is that the spontaneous force of the patients are not synchronized with the vent. There's less risk here of large swings of pressures and transmembrane pressure. Well, if you want to target the 10-10-10, especially the 10 of respiratory rate, you need to polarize the patient. We have seen during the COVID that the driving, the respiratory drive of these patients was very high, especially during the first week. So the only way to fully control the respiratory rate was to polarize the patient. So the APRV mode might be a good way here to let the patient breathe a little bit by himself with more tight control of the mechanical ventilation. And obviously, the driving, which is determined here by the PEEP and the high pressure, also gives you a good idea of the compliance, just having a look at the tidal volume, which is generated with these tidal volume. And when the tidal gets over 200, let's suppose that we have a driving of around 12, it's a good indication that, well, you may test windability in those patients. But okay, there's no, for now, scientific evidence. And I mentioned the Romeo and Countdown studies, which are now underway, which would be very interesting to analyze here about the strategy of mechanical ventilation under ECMO.
Wonderful. Thank you, Dr. Combs. Dr. Peake, do you have another comment here?
I would actually pretty much agree with Alain on this. I think that you need to have enough PEEP that you're above the opening pressure. And so, you know, pragmatically, that's usually between about 10 and 15. And equally, I think that if you want to limit the respiratory rate to 10, you do have to paralyze the patient. And I would not be an advocate for that. Certainly when you go on, you know, the patient's anesthetized and paralyzed unless you're putting them on a wake. I completely agree. I think the principle is that you don't use too much driving pressure and that you don't try and open the lung at the beginning of the illness.
Okay, wonderful, thank you. In the interest of time, maybe we'll move on to another question. Dr. Mina, was there a question you'd seen that you wanted to bring to our speakers?
Actually, I would like this question about one of the question here was stated that how about if you don't have esophageal pressure catheters available to you, or how you manage the ECMO patient if you don't have any some of this technology or access to this process?
Okay, maybe I can
Yeah.
comment here. Yeah, sure. I would say at the moment, as you've heard, I think we have lots of ideas. You've heard from all of us that, again, lots of ongoing research, lots of biological rationale for monitoring in VV ECMO patients that could include things like esophageal pressure. I see a question just popped up in the chat about EIT. You know, routinely measuring things like compliance or elastance of the respiratory system, maybe measuring things through occlusion tests like P.01 or PECOC. I think these are all very interesting. Again, in the end of the day, to move the needle, the monitoring has to make us or guide us in making a change that improves the outcomes of patients. And at the moment, I would say there's a dearth of clinical evidence in ECMO patients to suggest that many of these maneuvers are, at least at the present time, ready for prime time bedside action. I think we have lots of ideas about how they could improve future clinical protocols on how to manage their ventilation, how to wake them up safely, how to have safe spontaneous breathing, maybe how to liberate them or wean them from ECMO, what modes might be most helpful in those situations. But just to caution the group, again, and I'm just going to speak for myself, I'd love to hear the thoughts of the other members of the panel. I'd like to say that, again, more monitoring, like many things, increases complexity. And we want to increase complexity when we're pretty sure that increasing complexity is going to help the patient. So at the moment, I would say many of these things, all of us on the panel, many of us on the panel are researching, like looking at how EIT, like Professor Combe and his colleague, Professor Schmidt, done very many elegant studies looking at EIT and what its utility could be in setting PEEP, personalizing mechanical ventilation on ECMO that seem promising. But we need to test these things to be sure that the trade-offs are beneficial for patients. So I think at the moment, many of these things in my mind are the targets of clinical studies and clinical investigation, but not necessarily translatable directly to the bedside for the management of these patients. So to give you a very practical example, like in my ECMO patients, I'm not targeting a specific driving pressure, mechanical power, esophageal pressure swing, or these sorts of things. We monitor all these things actually because we're conducting research into many aspects of these things, but they don't inform the clinical protocol by which we manage ECMO patients in my unit at the present time.
Actually, Dr. Newman, Professor Newman, and also was echoed by Dr. Alali, about the utility of APRV pre-ECMO. Dr. Newman mentioned there's a patient 30 days on the ECMO, and they tried ARPV. And also, what is the role of TCAV in pre-ECMO or while on ECMO?
Okay, so I may answer that question. There was a trial in France, recently published, the BIRDS trial. It was published in Intensive Care Medicine, testing APRV versus volume assist control ventilation. There was no difference at all before ECMO on the regular ARDS patients. For now, we don't know if APRV or pressure support mode is better than a volume assist control mode in those ECMO patients, or a very gentle ventilation, which may be called near apneic ventilation. APRV was originally described as releases of pressure. The patient remained mostly in the upper pressure, which might be associated also with some lung injury, ventilator-induced lung injury, or hemodynamic compromise as well. The only advantage of APRV versus a regular BiPAP mode is that, once again, there's no synchronization of the patient respiratory efforts with the vent, which may end up with less swings of the transpiratory pressure. But once again, for now, those are only hypotheses, and we need more, and we need to build data RCTs to test those concepts.
I hope that answered the questions raised by a couple of people. I have a question, but I'm not going to go about the technical. Is there any bias in putting patient on ECMOs?
It depends. I think we all have biases. I think that there's a massive bias for, the whole history of intensive care medicine from the 1950s until, I think, perhaps 2009, that the ventilator was a fantastic invention, and that everybody should have a ventilator. And I think that now there are ECMO enthusiasts, many of whom are on this webinar today, who would challenge that. I think we all have biases all the time, and I think we just have to try and do the best we can with the evidence. But at the end of the day, when the patient's dying in front of you, I think it's very easy to make the decision and put them on. I think the problem is the patients who are a little bit hypoxic and are kind of outside the lung protective ventilation window slightly, but are not dying. And then it gets to 9 days, 10 days, 11 days, 12 days. Oh, they improved a bit. The new intensivist comes on for the week. Oh, I can make them better. I've got this new mode from Draeger that has only been invented last week. And let's check, right? That's what we do. I think you have to be pragmatic. I'm obviously biased in favor of ECMO, just in case you didn't know.
I think we might have 1 more minute, and I'll do the closing remark. There's a question about patient transported in prone to ECMO centers, or you prefer to cannulate them at the site, put them at ECMO and transport them, or prone them and bring them prone and cannulate them? We have like 30 seconds for that. We're willing to answer.
Option 2.
I agree.
Okay. For the last half minute, I would like to thank all the speakers for the great talk and great knowledge. And on the behalf of Society of Critical Care Medicine, ARDS Innovation KEG, I want to sincerely thank the outstanding speakers, and also special thank as well for our guest and moderator, Dr. Richard Greendyke, for guiding today's discussion and moderating the session, and to all of you in the audience for joining us, for your commitment to improving care for our critical care patients. And also thank you for the really interesting questions. Before we close, I would like to remind you about our activity and upcoming webinars. In September 30th at 3 p.m. Central Time, we have our Redefining ARDS from Global Consensus to Future Directions by Professor Micah Mahati and Professor Caroline Calfee. And in October, we'll continue our educational sessions with another webinar about precision mechanical ventilation in ARDS, which is featuring Professor Martin Tobin and Leonard Brochard. So we look forward to seeing you at this exciting session. Thank you again for, I thank the speaker, the moderators, and all of you for joining us at this great topic and great lecture that I learned myself. Anything, and also thank you for your all interesting questions. Javier?
Thank you all. Thank you for